Hi, Miss Nikki here. Welcome to Chapter 8. We're going to cover Part 2. We're going to look at the appendicular skeleton, so the upper and lower limbs. Just to cover again, we're going to talk about the appendicular skeleton, the pectoral girdle, if you want to think of shoulder, and then the upper limbs that hang off of the pectoral girdle. And then we're going to talk about the pelvic girdle, which would be the hip, and then we're going to talk about the lower limbs that hang off of the pelvic girdle. Nice representation of the appendicular skeleton. We can see here the pectoral girdle. So the pectoral girdle includes both the clavicle and the scapula. And then we can see the pelvic girdle, which includes the os coxae. So there's a lot of names used for the hip bones. You can use coxal bone. You can use os coxae. There's also ossa coxae. So this would be 2, right? Times 2. So this is the plural. This is the singular. Do not use hip bone. I mean, hip bone is what we say when we're in middle school, right? So hip bone, no. Coxal bone, os coxae, ossa coxae. And then we can see that the lower limbs listed that hang from the pelvic girdle. Just a reminder, pectoral girdle supports the upper limbs, consists of the clavicles and the right and left scapula. One point to make here is that this is an articulation with the trunk, and remember the trunk is the axial skeleton. We'll see another articulation point with the axial skeleton when we get to the sacrum and we talk about the pelvic girdle. Here we have the clavicle. You can see that there is a right and a left clavicle, that it attaches or articulates to the manubrium of the sternum, and then over here to the scapula. So the acromial end goes to the scapula side, and obviously the sternal end is going to attach to the sternum, specifically the manubrium of the sternum. Now we move on to the scapula. We can divide this image in half. We have an anterior view, so a front view, and we have a posterior view, a back view. We can see that there is a medial border and there's a lateral border. So here we can see that the medial border is more towards the middle and the lateral border is more towards the outside. We also have the glenoid cavity, and that's going to be the articulation point for the humerus here. Remember, we just talked about the clavicle and the acromial end of the clavicle. Well, it's going to articulate here with the acromion feature on the scapula. Next, we have a coracoid process. Some people call it a bird's beak, right? This is going to be an attachment point for your biceps brachii. Several other muscles articulate here or attach here, but we'll talk about those when we get into muscles. On the posterior side, we want you to see the spine. So this is a feature specific to the scapula, and I'm sure we have felt that ridge, right? If you reach your hand over your shoulder blade and you feel for that spinous process or spine on the posterior side of the scapula. We have a nice list here of all the bones of the upper limb. So just one side, and remember we have a right side and we have a left side. So all of these numbers would be multiplied by 2 if we were looking for a total. So there's one humerus on the right and one humerus on the left, one radius, one ulna, 8 wrist bones, 5 metacarpal hand bones, and 14 phalanges or bones of the fingers. Here we have the humerus, and the humerus is going to articulate with the radius and the ulna. We're going to focus on this distal section the most, but real quick, let's just mention that the head of the humerus is going to articulate with that glenoid fossa that we just talked about, or glenoid cavity. Sometimes people call it fossa as well. So that's the articulation point between the humerus and the scapula. We can see as we move down to the distal section, there's a lot going on down here. So on the anterior view, so the front view, we have the capitulum and the trochlea. These are going to articulate directly with the radius, so the capitulum and the radius, and then we'll have the trochlea and the ulna. The trochlea to me is kind of a square or rectangle shape, and the radius attaches to the capitulum, which is kind of a rounded shape. So here we can see the roundness of the capitulum. So I know that the roundness of the radius, those are going to be articulation points. And then here I've got kind of the more square trochlea. I know that this is going to be my ulna site of articulation. We also have a fossa on the anterior side, but it's much smaller. So here's the fossa on the posterior side. So anterior, we have the coronoid fossa, and on the posterior side, we have the olecranon fossa. So much larger on the back side or posterior side. The other item that we have to look at are these epicondyles. So you see how the shaft comes down and it kind of juts out on both sides. So the lateral and medial epicondyles depend on the position that you're looking at. So here, this is lateral because it's facing outside, and this one is medial because it's more internal or facing towards the middle. But if I'm looking at a posterior view, these names don't change, but the view changes, right? So we still have medial here because it's more towards the middle, and we have lateral here because it's towards the outside. So these epicondyles are just bony projections that stick out past the capitulum and the trochlea. As a follow-up, just make sure that we understand why we have these bony features. So these epicondyles are going to be sites of attachment. And they could be sites of attachment for ligaments, right? So ligaments that hold bone to bone. Or they can be tendon attachments. If we're attaching a muscle to a bone, right? Muscle to bone. So anytime you see some roughed feature on a bone, there's probably an attachment point. So think about the deltoid tuberosity. So it's this protruding, roughed section of the shaft, and it's probably an attachment point for your deltoid or your shoulder muscle. So anytime we're talking about these, we're probably going to come back and talk about some muscle being attached to them later. So we didn't just arbitrarily pick out all of these features for you to know. There's a rhyme and a reason to it. Here we have the radius and the ulna. Let's look at the radius first. Here's the radius. We can see the head of the radius, and we can also see the radial tuberosity. So this little roughed projection, radial tuberosity. If you hear the term tuberosity, this is probably going to have something to do with muscle attachment, right? Down here at the end of the radius, we have the styloid process. This is going to kind of act as a border to help protect or confine all of your carpal bones. So here we're going to have carpal bones. So to me, they kind of act as bookends, the styloid processes. So on the radius, we have a head, we have the radial tuberosity, and then we have this styloid process on the end. And remember that the radius, I put this image from the humerus back up so we could look at it again. Remember the capitulum, the rounded capitulum is going to articulate to the rounded head of the radius. So everything's kind of that rounded shape. And you can see it here. Capitulum, radial head. Now we move on to the ulna. So I'm going to look specifically at the ulna here. We have a trochlear notch, and they named this really well because remember, here's the trochlea of the humerus. So what do you think we do? We take the trochlear notch of the ulna and it articulates, here's the trochlear notch of the ulna, articulates to the trochlea of the humerus. On the back side, the posterior side, we have the olecranon. Remember how we had the olecranon fossa on the posterior side of the humerus? Well, the olecranon process fits into the olecranon fossa. This is your elbow. So if you were to fracture your elbow, you actually fractured your olecranon process of your ulna. I kind of covered it up a little bit, but there's this little kind of pinpoint, there's a apex, if you will, in the ulna, and it's called the coronoid process. This is going to kind of bear the weight or guide the movement if you go from your arm straight out to flexation, if you bring your forearm closer to your shoulder. So that coronoid process is going to help bear some of that weight. Let's see, what else did we want to talk about? Styloid process. So styloid process, just like we have a styloid on the radius, and that's going to help frame your carpal bones, right? Supination is what we're doing in anatomical position. The radius and the ulna are both parallel. Think of it as if you brought your hand in front of you and you were holding water in your hand, right? You're cupping something, you're holding a bowl of soup, you're holding something in your hand. That would be supination. I think of pronation as your hand out, where the backside of your hand is facing up. Students, we joke about, I now pronounce you whatever, right? Married. So this is, if you were trying to put a ring on somebody's finger, you would flip over the palm. When you do that, the radius crosses over the ulna. So we have this twisting motion, and we're able to do this because of the features of the radius and the humerus. So remember, this was the capitulum, which kind of has a rounded shape, and then the head of the radius has a rounded shape. So this is why we're able to do pronation along with a muscle, the pronator, that we'll talk about when we get to the muscle chapters. Now we move on to the carpals, the metacarpals, and the phalanges. So the carpals are going to be wrist bones, and we have 8 of these. You can see the styloid process that I told you about earlier that help kind of frame the carpal bones. For my class, you do not have to memorize the carpal bones, but there are some mnemonics if you wanted to learn them, if you knew you were going on into, let's say, PTA, or you knew this wasn't your final destination, you might want to learn them. There's some fun mnemonics. Sally left the party to take Kathy home. So if you want to look up mnemonics, sometimes it's fun and it helps. Here we have the metacarpals. So this would be the hand, the bones of the hand, and we have 5 of them. If you don't know your Roman numerals, go look them up. We're going to need to know them for cranial nerves. You'll have to know all of them then, so you might as well learn them now. Number 1 would be your thumb, and pinky would be 5. And then here we have the phalanges. So there's 14 bones of the phalanges, and individually they're called phalanxes. So a phalanx is singular, phalanges is plural. And you can see we have a proximal, a medial, and a distal phalanx on phalanges 2 through 5. For the thumb, we just have a proximal and a distal. We do not have a middle phalanx on our thumb or on our big toe that we'll see later. This would make the thumb way too long, and this would impede some of our fine detail actions that we can do with our hand, like writing. Now we move on to pelvic girdle. We've talked about how the 2 coxal bones make up your pelvic girdle, or os coxae. But to make up your entire pelvis, that bowl-shaped structure that supports all of your abdominal organs, we also include the sacrum and the coccyx. So remember, these are axial skeleton bones. And then we have our os coxae, which are appendicular. So this is another area where we have the axial skeleton articulating to the appendicular skeleton, and lists here that we're supporting all of the organs or viscera in the ventral body cavity. Nice image here of the 4 bones that make up the pelvis. We can see the sacrum, the coccyx, and we can see the 2 os coxae. I want to point out the pubic angle, sometimes referred to as pubic arch. And then here we have the sacroiliac joint. So right here where the sacrum and the ilium section of the os coxae is where we have the sacroiliac joint. So this would be an articulation point between the axial and appendicular skeletons. Let's look at some of the overall features and regions that make up the os coxae. We have an ilium region, and that's this fan-shaped region. We have the ischium, which is this rounded region, and we have the pubis, which is this pointed region. So the ischium faces towards the posterior, the pubis faces towards the anterior, and all of these three regions were separate bones that became fused to form our os coxae. Overall, what we need to look at is the acetabulum, and this acetabulum is important because this is where the femur is going to articulate. Another region that we need to look at, or a feature that we need to look at, is this foramen that's created. So this obturator foramen. Obviously, if we have a foramen, it's a hole. If we have a hole, there's a reason, right? I'll talk about it if you don't remember why. I mentioned it before, but I'll mention it again. Let's just talk about the ilium real quick and the features that we would need to know for the ilium. One, we have this iliac crest. Two, we have this greater sciatic notch, if you've heard of your sciatic nerve. And then here we have our lesser sciatic notch. On the back side, we also have to mention the rough feature where we're going to have our sacroiliac joint. So I'll show you that on the next image. We're still talking ilium, right? We're still here at this top fanned out section, and you can see here that this would be the articulation point for the sacrum. Remember our sacroiliac joint. Now if we look at the ischium, on the ischium region of the os coxae, the feature that I want to look at is the ischial tuberosity. This is going to be an attachment point for your hamstrings. And we'll learn the real names of those three muscles, but your posterior thigh muscles attached to the ischial tuberosity of your os coxae. On the front side, we have the pubis, remember the more pointed section. The feature that we really want to focus on with the pubis is going to be the pubic symphysis, which I'll have to show you another picture. Symphysis, there we go. This image, you can see the pubic symphysis of the pubic region. We previously talked about the pubic arch or the subpubic angle. So those are the features from the pubis that you need to know. So if I broke this up, for the ilium, you need to know the iliac crest, you need to know sacroiliac joint, you need to know greater and lesser sciatic notches. For the ischium, which is hard, that's on the back side, right? The ischium, you need to know the ischial tuberosity. For the pubic region, you need to know the pubic angle and the pubic symphysis. For overall description of the pelvis, you need to know that acetabulum, where the head of the femur fits in, and then the obturator foramen. So previous slide, I alluded to the obturator foramen. Why do we have the obturator foramen? Well, some nerves and blood vessels are going to travel from the pelvic area to feed the anterior portion of the leg or the lower limb. So some nerves and some vessels are going to pass through this obturator foramen and innervate the anterior portion of the lower leg. On the back side, we do have the sciatic nerve that's going to come out and run on the posterior side. It doesn't go through the obturator foramen. That's why we have this greater sciatic notch and this lesser sciatic notch. And that sciatic nerve is going to innervate or feed the backside or posterior side of the leg. So these areas become pretty important if we have several hip muscles here, right? Our gluteal muscle attachment, our hamstring muscles are attached here. Once we go through the muscle section, we'll see how all of this is in play and how that sciatic nerve can become inflamed and pinched, and then you can have pain radiating down the posterior aspect of the leg. Some words that you might hear: true pelvis and false pelvis. You can see here that the false pelvis is really the ilium region of the os coxae, where the true pelvis is the pubic, the ischium, the sacrum, and the coccyx. You might also see the terms pelvic inlet and outlet. You can see the inlet here in the dashed blue line. And you can see that incorporates part of the ilium. So you might also be thinking false pelvis, right? And then the pelvic outlet is this space here that's bordered or defined by the sacrum, the pubic symphysis, and the ischial section or region of the os coxae. What are some of the sex differences in the pelvis? Kind of similar to what we saw in the skull. Remember, the skull, everything was kind of more box-shaped, more pronounced in the male. So this is the male pelvis, and this is the female, where we have kind of this more wide, rounded structure. Also, something to notice is that the pelvic arch in females is, again, more rounded, where the males is more pronounced. Again, here's the male coccyx versus the female coccyx. So would it evolutionarily make sense to move the coccyx bone farther away from the pelvic outlet? That would kind of make sense, right? Especially if we have a child being birthed from the pelvic area. Again, we have a nice list this time for lower limbs. Remember, everything's times 2. So we have a femur, patella, kneecap, right? Tibia, fibula, pay attention to the endings. 7 tarsal bones. So remember, tarsal are going to be ankle. And then we have metatarsal, so that's going to be bones of the foot, right? And then we have phalanges, which are going to be the toes. Now we move on to the femur. You can see this very pronounced head of the femur, especially compared to the humerus, which has a much shallower head. You can see the fovea capitis. That's this little indentation. We actually have a ligament that's helping to secure the head of the femur into the pocket or the acetabulum of the os coxae. Next, we look at the greater and lesser trochanters, and you can see these nice hook-like structures, whether you're looking from behind, posterior, or anterior view, and we're going to have muscles attached. So you can almost bet anytime you have a hook, there's going to be a tendon attached to that area. If you've ever heard of the quads, you know we have 4 muscles that are going to hang on the anterior thigh portion of the skeleton. We can also see these terms come up again, epicondyle. So remember kind of those surface features that kind of jut out. We have an epicondyle. Epi means upon. And we also have a condyle. So the condyle is the rounded section here, and the epicondyle is the bony extension above it. So these epicondyles, we're probably going to have some sort of attachment point. It could be a ligament, because remember we have the tibia and we have the fibula. So it could be an attachment point like a ligament, or it could be attachment point for a muscle, right? So a tendon. The condyles are where we're going to see the actual articulation. So condyles are kind of rounded structures, right? So these rounded structures are going to help glide, and you're going to see they're going to be attached to the tibia. We'll see how the fibula is really just a supporting bone. Patella, this is our kneecap. This is going to sit anterior to the knee joint. It's going to act as protection, and it's also going to help kind of with a gliding of the tendon And the tendon I'm talking about is the tendon from the quads, those muscles that we'll talk about when we get to the next unit. We can see the protective nature that the patella is offering the knee joint. It sits directly in front of the femur and it sits superior to the tibia, and you can see that it's directly anterior to all of the ligaments that would be holding the femur to the tibia. The other thing that I wanted to point out is here is the fibula, and the fibula is really a supportive bone. It's not bearing your direct weight. If you look at all the weight from the skeleton above, it goes from the axial down the pelvic to the femur, and all of that weight gets placed on the tibia. And your knee joint is kind of the point of weakness there. The fibula is really just an anchoring or supportive bone. Now we talk about the tibia. Something to pay attention to, this is the anterior, right? This is our anterior view. The tibia is the medial bone. It's on the inside. The fibula is the lateral bone. It's on the outside. So I always think lateral, LA. So fibula is the outside bone, tibia is the inside bone. You can see here the lateral condyle and the medial condyle on the tibia. This is where the femur is going to articulate. Do you remember that the femur had a lateral condyle and it also had a medial condyle? Well, the lateral condyle of the femur is going to articulate with the lateral condyle of the tibia. The medial condyle of the femur is going to articulate with the medial condyle of the tibia. Kind of convenient, right? Then we have this tuberosity. Anytime you see tuberosity, you should be thinking muscle attachment. When we get to the muscles, we'll talk about the tibialis anterior, and this is the attachment point. You might be familiar with the tibial tuberosity as your shin. So the kind of rough bony projection directly below your kneecap or patella. We have to move down and look at these end projections or features. We can see here the medial malleolus. This would be your inside ankle. It's not technically your ankle, but that's what we think of it as. Does this look familiar? Bookends. What's going to be here? Instead of carpals, we're going to have ankle bones, tarsals. So this medial malleolus would be that bony protrusion on the inside that we usually refer to as our ankle, but it's not really your ankle. It's kind of the support for your ankle. Now we look at the fibula. The fibula, you can see here, is attached to the tibia, and it runs the length and really makes up the lateral support for the ankle. So just like we have a medial malleolus, we have a lateral malleolus on the fibula. Remember how I said the fibula is really just a supportive bone? Its real function is to support those tarsal bones. It doesn't have any weight-bearing capacity. All of your weight is being displaced on your tibia. Now we move to the tarsals. Remember, you have all of the weight from your tibia, and it's all being put on the talus. And from the talus, it's spread out to the calcaneus. This would be thought of as your heel bone. So these two, you do have to know their names because they're important in distributing weight. The rest of the tarsal bones, you do not have to know their names. You should realize there are 7 tarsals where there are 8 carpals. Then we move on to the metatarsals. We have 1, which is the big toe side, and then we have 5, which is the pinky toe side. So kind of same setup as the hand. We still have proximal, middle, and distal phalanx that make up phalanges, and for the first digit, we only have a distal and a proximal. There is no middle. I did want to mention the arches. This is the medial arch on the inside, and then on the back side you do have a lateral arch as well. I just wanted you to realize that these are important. They're maintained by the bone structure. They're also maintained by the ligaments, so bone-to-bone ligaments. They're also supported by tendons. So we have tendons that are attached, and so whether these tendons are strong or weak is going to depend on what type of arch we have. Also think about all of the blood vessels that have to innervate the bottom aspect of the foot. So you do have blood vessels where if you are flat-footed, you're standing on those blood vessels and you're blocking the flow of blood to the underside of the foot. Skeleton formation, remember most of the skull bones form by intramembranous ossification. Most of the other bones of the upper and lower limb are going to form through endochondral ossification. So usually we don't see the appendicular skeleton start to develop till about the 4th week. You'll start seeing limb buds, and then eventually you'll see kind of a more standard looking appendage. The development of the appendicular skeleton has been studied, and we kind of follow it through this progression. Here we are at week 4. This embryo is human, but if I were to look at a pig or a chicken or a cow or a rabbit, this week 4 embryo would look very similar. And what's going to happen is basically our genes are going to turn on and off different growth patterns, and we're going to develop these appendages that are going to develop our upper and lower limbs. And this is all through signaling in utero. So as you're growing in mom's womb, these genes are being turned on and off at different times to develop these human appendages. So obviously, if all of this signaling is occurring in utero, there are genetic or environmental influences that could cause limb malformations. There's polydactyly, where you can have extra digits, either fingers or toes. You could have the absence of a digit. When our limbs are first formed, there's webbing between our fingers and toes, and that webbing has to be broken down, and sometimes that doesn't happen. Sometimes you can have digits that are fused together. You could also have a poorly formed limb, or you can have the complete absence of a limb. So there's a lot of malformations that can occur due to either genetic abnormalities or environmental. So unfortunately, sometimes we don't find out that certain drugs cause limb malformations until it's too late. So this was a sleeping aid that was marketed to help you, and that you could take it while you were pregnant, and it caused severe disruption of limb formation. So hopefully we're not too overwhelmed by Chapter 8. Again, I can't stress this enough. Do the lab quizzes repeatedly until it just is the name pops into your head. Before you do the lab quizzes, go through APR and look at every single bone and every single bone feature. I'll talk to you next PowerPoint. Bye.